Welcome Dr. Krushna Chandra Sahoo, sir, and look forward to an insightful session. Sir, over to you, sir.
Sir, we'll start, sir.
Hello, sir.
You are audible, sir, now.
Sir.
Thank you. Thank you, sir. Thank you, sir. So let me share my screen. I think it is visible now, no? Okay. So within this last 3 days of journey, we learn the exposure to various means statistical software like STATA and R, and also how to interpret it. I assume that you must have some basic STATA understanding skills. And yesterday also. You have a very brief and discussions about systematic review and meta-analysis, why it is needed, and what are the various components of systematic review. So today we'll discuss about the meta-analysis using STATA, its implementation, assessment, and interpretations. I think we'll be go both in presentation and practice mode. I had already discussed with the sir regarding some of you exposure to STATA, some of you are not exposed to STATA. Therefore, my intention or objective of the study will be to give a overall idea why we use meta-analysis and what are the various type of basic meta-analysis, and I'll give you the command which you can use in the STATA, and still some limitation in the STATA where we cannot perform certain type of meta-analysis. We need also R. Then maybe tomorrow you will be detailed discuss about R. Okay. So let us see that systematic review and meta-analysis. If you see the you cannot do meta-analysis without the systematic review. So a meta-analysis is often a component of systematic review, but not all systematic review include a meta-analysis. So that's why systematic review is basically qualitative in nature. It is qualitative in the sense it is not by qualitative study. That means not much statistical interpretation is not needed. So, it could be a qualitative systematic review. It could be a only descriptive level systematic review. But meta-analysis is hardcore quantitative synthesis. That means to do meta-analysis, you need uh, adequate number of quantitative data in a homogeneous manner. Then you will do a meta-analysis. But the first steps of meta-analysis is that systematic review. Then in systematic review, what is the methods? The method is a structured literature review. So we are doing a literature review using a structured approach. We'll use certain number of database, specific search strategy. Then we are designing our research question accordingly. Then we are screening. So all steps we are following. Once we follow all the steps, then extract the data, then we prepare a data matrix. Then we'll see either this study or this systematic review is enough to do or have enough data or quantitative variable or quantitative data to do meta-analysis or not. Then we'll be do the statistical pooling of data. In systematic review, just we are summarizing findings. There is no pooled estimate. However, in meta-analysis, we are produce an overall effect size. So why this effect size? What is the importance of this effect size? So yesterday, Dr. Gita Mena ma'am explained you. So today we'll see with some of the example. And a dependency, that means can exist without meta-analysis. Systematic review we can do without meta-analysis, but all the meta-analysis require a systematic review as a base. So this is the gist. That means we must need a systematic review in order to meta-analysis. And not all the systematic review need meta-analysis. Wherever the adequate number of data, quantitative data is there, then we have a statistical pooling of the data. Then these are the steps. I'm just debriefing. You yesterday learned. Maybe madam gave you in a different way, but all the steps are similar. You say first of all the resource question, then you can use peak or spider, then you have preliminary search of idea data, then you start with the inclusion and exclusion criteria. What is the inclusion criteria? What is the exclusion criteria in your study? Then you develop the search strategy. Then you need some searching databases. Databases means at least PubMed or Medline is there, then Embase, Cochrane. So at least 3 to 4 database you can include. Then you write the protocol. Then once you extract the data, then you screen the type. Means after you extract the number of article from various database, you can use some screening software, Ryan you can use, or Covidence you can use, whatever the screening software you can use, or even you can screen manually also. So then you prepare your Plasma flow diagram. Then you also start screening simultaneously. You can have screening of the article, abstract and title. You read abstract and title. Once you find out, okay, these many studies are included as per your inclusion criteria, then include that. After that, you do the full text review. Suppose 100 or 200 or how many article you think that after screening the title and abstract, these studies are now eligible for your review. But sometimes you know that you cannot judge all the studies based on the title and abstract. So that's why you have to do full text review. So when you do full text review, then you prepare a Then you thoroughly review the study, extract the full text of the article, then you thoroughly review that article, then you find out how many are included. And some of them are definitely excluded. Okay, once you get the number of the article which will be included in the study, then you extract the data extractions, extract the data. Before that also you can do quality assessment of the study. Meta-analysis only possible when adequate number of, suppose in your systematic review you include 30 studies, but maybe in that systematic review include 30 studies, only 7 studies is eligible for the meta-analysis, only 15 studies will be possible for the meta-analysis. That is possible because all the study you may not get the same type of homogeneity in data, or the what is your outcome variable, you may not get it. So but you can keep it. So then that means here why I want to show this, up to the data extractions you have to do systematic review, same principle. Then the meta-analysis is the next steps. Okay, now let us see that what is a meta-analysis. So meta-analysis is a statistical technique that combines the result of multiple independent study. Suppose in your systematic review you found 10 studies, study 1, study 2, study 3, study 4, like this 10 studies you included. So if you are, as per your outcome, you found what is the value, what is the percentage, or what is the number given in the study 1, study 2, study 3, study 4, then you can pull the result of all studies put together to address the same question. Means you have a single research question, you pulled the quantitative data as per your objective from all the included studies, then you do a meta-analysis, produce a single estimate of the overall effect. Okay, why it is used, where it is used? It is used in the clinical trial for the drug efficacy also. It is used in the epidemiological study for the disease prevalence, psychology and education intervention, or public health policy. Let us discuss this a little bit. Suppose there is a one drug for particular disease, there is a drug is there. Then how you know that effectiveness of this drug? There are certain randomized controlled trial study for the effectiveness drug. Then another new drug came. Now you want to use that drug. So then you found that 6-7 randomized controlled trial studies which test the efficacy of that drugs. So in that term of efficacy, they may take odds ratio, or they may take risk ratio, or whatever the statistical measurement they taken in all the studies. What is the effect for the control group? What is the effect for the in the intervention group? That means the new drug is the here intervention group. Then you find out which drug is really effective for that disease, or the new drug is more effective than the older drugs or older medicine or not. Similarly, in epidemiological study for the disease prevalence, disease prevalence, you can use this also type of meta-analysis, pooled prevalence, because you have a 10 study given different percentage or different prevalence value. But ultimately, how could you say that? How could you say that which one is what is the pooled effect or pooled value? We cannot say 10 value. Then you do a meta-analysis to that. Today we'll see that also. So which are very useful for any public health interventions or any psychology or educational interventions is very important. Second is a meta-analysis, often a component of systematic review, which already discussed, but not all review include a meta-analysis. So why we are doing, when you do meta-analysis, it increases statistical power by pooling the data, because we are pooling the data from different studies there, and which helps to resolves the inconsistency between the studies. If is there inconsistency in study also, helpful. Okay. Second, it ultimately provide a quantitative summary of evidence. So therefore we are doing meta-analysis. Okay. So what is the importance of meta-analysis? You know that it aggregate the evidence to guide decision making. When we are, like the last example we are given, for example, certain drug is there, what is the effectiveness of the particular drug? It is favor towards the intervention group, or it favor towards the control group. It favors towards the control group, then you can say that there is drug, the new drug is not more effective than the old drug or old medicine which have. So then you can have a clinical decisions. So, and this decision is not based on a single studies. What are the total number of studies you found in that area? You first thoroughly search using the systematic review approach in a systematic manner with using adequate number of databases. So then only you can say that, okay, you got this value. So that's why it is called systematic review and meta-analysis. And similarly also it identify the pattern or effects not visible in individual studies. Sometimes in individual studies could be bias, it could be not that, but if you have similar type of studies and pool that, then you can give a pattern also. And it also highlight the heterogeneity and potential bias in the literature, any heterogeneity or potential bias. So we can use also draw a funnel plot where you can see that in the meta-analysis you can draw a funnel plot, then it says that is there any bias or potential heterogeneity in the studies. Then once you identify any heterogeneity, then you can do also sensitivity analysis, or you can sometimes you can do also subgroup analysis. So these are the key importance of the meta-analysis. Then when you are using this statistical model in meta-analysis, basically you can use fixed effect model, or you can use random effect model, or other some advanced model is there like meta-regression, network meta-analysis, Bayesian meta-analysis. So since this is a basic course, so we will not detail discuss about this model, but you remember that either I will use fixed effect model or mostly random effect model. So when use, you know that we'll be see that when you use fixed effect model and the result or pooled value will be little bit different than the random effect model. In usually the fixed effect model, one true effect size underline is in all studies. That means variation is due to sampling error. So when there is a homogeneous studies, then you use the fixed effect model. Okay, but you cannot found that homogeneity in many cases within the study, and between the study there are a lot of heterogeneity. So in that case we are using the random effect model. Mostly we are using the random effect model. Okay, so why then here I can say that today will be discuss three important area. One is the meta-analysis of proportion or prevalence. Another one, the meta-analysis of diagnostic accuracy study. Since this course is the bigger course, it's part of HTA. You know that now there are many technologies there. Those people are from medical background, or those people are from even technology background also say. So what is the diagnostic accuracy studies, and how to choose which one is the best one? So we will be little bit focused on diagnostic accuracy study. Then at last we will be focused on the meta-analysis of randomized controlled trial study. It's RCT, using either odds ratio or risk ratio, or somehow mean difference. So we can do that. So for let us start with the very beginning. why meta-analysis of proportion or prevalence is very important. Meta-analysis of proportion or prevalence estimates is a commonly used in epidemiological and public health to quantify and summarize the burden of condition across multiple studies. So let us understand this with one example. So if I say, what is the burden of anemia, or what is the burden prevalence of anemia in India, how will we answer? Anyone can often and your means you can answer. Anyone can answer. If my question is, what is the prevalence or burden of anemia in India? So how will we answer? How you answer the questions? Anyone can answer. Sir, am I audible, sir? Hello.
Yes, yes.
So my question is, if my simple question I ask, what is the prevalence of anemia in India? So how will be search the answer? Suppose tomorrow you will write a proposal about the anemia prevention or anemia mukt Bharat in India. So then you have to show the burden of anemia in India. In that case, so in that case you need the value for your background. So you have to say that burden of anemia in India. Then you say that why. Then you can justify the rationale of the study, that why we need these studies. So where you will be get this value? Anyone can answer. Please participate in the discussion, because it's a online mode, but otherwise I prefer to more interactions. So how you will be answer? No one.
So based on government reports like an FHS.
So okay, very Devjit. Okay, Devjit. So you say based on the government report. So what are the government report is there? Possible government report is there?
National Family Health Survey.
Okay, you say that NFHS data you will say, but you know that NFHS this year they don't have the
Yes, sir.
any
Yes, sir.
anemia record.
They dropped the record for NFHS 6.
So what happened? You know that now. So yes, that is good. That anemia, you can say that from the NFHS data. Okay, that is one source. So any other source? Then NFHS, because we say that okay, it is a large sample survey from representing the whole country. So yes, we'll say that okay, based on data we agree. Okay. So let us some of the disease conditions, there is not any national survey. So in that case, how will we say that the estimate the prevalence in a country or global prevalence? How will we estimate? So
Based
let
on the
us
literature,
consider.
sir.
Okay, based on the literature, you say. Okay, so you can take another also programmatic data, because if every country or national program already you answer, so they have a collecting the data.
Sir, you are not audible, sir. Hello. There is some problem in networking. The South sir will join soon. He is connecting to from some other network. He is joining now.
Sorry, sir. I'm audible, sir. It was, okay. Uh, let me, mm, I guess PPT is visible also, na? So I, yeah, yeah, yeah. So, uh, so okay, what we discuss about that prevalence of anemia. So what happened now? We'll take the programmatic data. Otherwise, we can do that. But someone answer that question that we can do also literature review. So once we found the literature review, then will be found that many studies are there. Suppose you found 10 studies conducted across various parts of India. So then how will we say that study saying 40%, one study saying 80%, then in India? So in that case, meta-analysis is very useful. So why we are doing the meta-analysis for the proportion study? Because it estimates the pooled prevalence, combined prevalence data from multiple studies to produce a summary proportions. It useful when individual studies have varying sample size and result, and it also improve the that precisions, provide more precise estimate of disease burden than any single studies, which help account for random error in a individual studies. And it also access the heterogeneity, identify variability in prevalence across studies, population, or over time. So that suppose if you want to do that, what is the prevalence? Suppose you got 20 studies, you say that okay, we want to see the prevalence in the last up to 2000 what happened, and remaining studies what happened to 2000 to that. So you can also compare, you can do also subgroup analysis in this case also. So which ultimately support the public health decision making used in planning, resource allocation, screening strategy, or intervention, which is very essential in burden of disease studies. Finally, it also highlights the research gap. Suppose you conduct a meta-analysis, you found, okay, there are not much literature in this area, then it identify, okay, these are the area for further research, guided future studies and surveillance program. So these are the reason we need the meta-analysis in studies. So when you do meta-analysis, that you can present your result in a figure that is called the forest plot. So the forest plot will be, looks like this. Here you can say that okay, the 95% confidence interval, here where is your studies value lies. So this way you can present the result. Now let us discuss the meta-analysis of a proportion study or prevalence study using the STATA command. Usually in STATA we are using the command, that meta-prop. Okay. So first of all, you need to know about the data set, what I already discussed. Once you do systematic review, then for the meta-analysis you need enough or adequate quantitative data in the included studies. So suppose let us assume that we want the prevalence of anemia study. Then you need events, means number of cases, and in its study, what is the number of cases, anemia cases, then what is the total sample size in study, then if you want to subgroup analysis, either it is happen in the rural area or urban area, anywhere, any subgroup. But these 3-4 variable, then you just run this metaprop command, metaprop with event sample size, then definitely you have random model, FTT random model, then you rival, then name variable. That means you can say your study ID is the name variable. What are the yellow color things highlighted? that value you have to give. Otherwise, that everything are fixed. So then if you want to do subgroup analysis, you can do subgroup also. So I think let us explain this, then we'll be run using in the STATA. So suppose this is just studies. We want to say that, okay, using various sanitation facilities, improved sanitation facilities or unimproved sanitation facilities. These are from the different studies, value given, and these are the total number of sample and how many have unsafe disposal practice. So when they have improved sanitation facilities, how many have unsafe disposal practice? When they have unimproved sanitation facilities, how many have the unsafe disposal practice, unsafe fecal disposal practice? So this is in this way, if you want to say the anemia, prevalence of anemia, how you organize data, then you can say each study, you can say study 1, study 2, study 3, author, ATL and year wise you organize your study. Then you say that, okay, either it is rural area or urban area, you can mention, or peri-urban area, or you can say that anemia among male and female, whatever the available information is there, you can do that. Then you can find out total sample in each area. You know that sometimes you will be not get data as directly given in the paper, some manuscript or in the research article. You have to extrapolate the data. So that means total sample, and among them how many are have the anemic cases. So this way you have to organize your Excel sheet in a row and matrix format. Once you organize your Excel sheet, then simple you run it in using the command in STATA. So then once we see this is the data matrix, once we put this value, we get a result like this without any subgroup analysis. Subgroup analysis here means what is the overall prevalence of unsafe disposal here. Then is there any difference in the improved sanitation versus unimproved sanitation practice, or the unsafe the fecal unsafe disposal practice is same, those who have improved sanitation facilities and those who don't have improved or unimproved sanitation facilities. So then we'll do the subgroup analysis here. So if you see this graph, this is called the forest plot. In this forest plot, you say each study wise, what is the unsafe disposal practice they given. So you know that the study 1, it is 53.8 with confidence interval. That show weightage of each study is given also. So you can see each study have the given value. Some of the study also 100 also given. If you see overall prevalence, the last column, biggest triangle one, it says estimate of the value, full estimate of the overall unsafe disposal practice in India, fecal disposal practice in India. So we didn't have any subgroup analysis here. So you just enter this value, then you import your Excel to the STATA, then simple you write this command, metaprobe command, then event means here you have to give, event means you have to give in here unsafe disposal variable, then here you have to given that sample size, total sample size. Then this is random model we are using, name var. Here you can give name var as a that study. The study is the name var. If you want to stratify, then by sanitation facility. So these simple things use that. If I same things I will do a subgroup analysis, then you will be get this result. Here you see 69.33 pulled value. When I do subgroup analysis, see, definitely there are heterogeneity subgroup analysis with fixed effect model. Okay, here is a random effect model using Then here same things, I did subgroup analysis with fixed effect model. Then you can say improved sanitation. What is the pooled? 55.78. And what is the unimproved among this group? Pooled prevalence is 85.87%. Okay, so overall 73.28 the value is given overall using fixed effect model. But here you can see also the those who are using unimproved sanitation facilities, they have higher means that higher number of unsafe disposal practice, that is 85.87. So this is given. Okay, so similarly I assume that there is a more homogeneity, but it is not true. If I same subgroup analysis will do using the random effect model, see the value change now. So in fixed effect model, the overall heterogeneity is showing 0, because I assume that there is no heterogeneity homogeneous group. So the heterogeneity I square value is given 0. But it is not true. There are a lot of heterogeneities there also in these studies. So here you can see that 69.33 pooled effect size. If you see that I square also highly heterogeneity, 99.85%. But similarly also it gives the value using both in the improved sanitation group, what is the unsafe disposal practice, as well as unimproved sanitation facility group. So both the value it is given. So this is the use of that meta analysis. So now I can show this you in the using STATA. Let me open my STATA. Sir, my STATA screen is visible now?
Yes, sir.
Jitendra, my STATA screen is visible?
Yes, sir.
Okay. So now I just open the STATA. Yes. I'm just opening the STATA. Now what I'll do, I'll be import my Excel sheet, just simple file, import. Then I import my Excel sheet. Then I will be browse. I prevalence data. I'll use this one, prevalence. Just I open. Then I select import first row as variable. Then OK. So if I say that, if I describe my variable, okay, these are the things. That means we have 12 observations, 4 variables. Okay, 12 studies, 12 observations. Now I want to do meta-analysis. Simple, I will be just write the command. So let us start it. So what is the command here? I say for prevalence, metapro. Then once you have metapro, event. Here is the event. Event is the here unsafe disposal. Case sensitive. Instead of typing, you just do that this way. Then total sample size. Here total sample size is total sample. Then what I will do, I will use a comma. Then I use FTT. If I want to, let us see in the random effect model. If I want to, it's random. Then random. Just type random. Then I'll do level. Level means the study variable name. What level? So in level, name var, va var equal to, here name var is my study. Okay, name var is my study. Okay, then I just close this. Then let us run. So while I run, see this figure. So it is without subgroup analysis. So it is without subgroup analysis. This graph is shows without subgroup analysis. So you can check, then you can remove some of the studies. For example, these studies is very 1.0. I can remove also from the analysis. You can see heterogeneity. You can use funnel plot. Then you can do that. So this is simple command you can use. Okay. Now let us, if I want to, here also detail table is given. If I want to see, okay, but in this figure, you cannot say, you will say that overall see that. You know that the now overall unsafe disposal is 0.69 percentage among all these available studies in India. Because we use here random model, still there is a high heterogeneity. You know that I square is 99.85. Usually it should be less than 50% heterogeneity I square. But you know that some study has very larger sample size, some study are very small sample size. So that's why your I square. But the less heterogeneity is there, less I square value is 50% less than 50%. That is good. I got I square is value this much because we use random effect model. Okay, if I just simple same command instead of random, I use just fixed FIXED. I little bit change the command. Then let us see. Is the pooled effect same? No, it is 0.73. Again, you know that heterogeneity I square value is saying 0% because we assume the homogeneity. When I assume the data there is a homogeneity, use fixed effect model, but which is not possible. So that's why often we use random effect model in the studies. Okay, but these both random effect model, fixed effect model, using without any subgroup analysis. Same things if I say what is the prevalence in the different group. So I took assume you can have 3 group of, you can have 4 group also. Just what I'll do, same command I will write here. Let it be random. Same command metapro unsafe disposal. That means total number of event occur. Then total sample size in each study. Then FTT random. Label means what here. If you are not giving any label variable, you will not get here this which ETL study ETL wise. Okay. Then here what I will do, I will be classify them by start the bracket sanitation facility. So here the variable we took sanitation facility. Whatever variable you want to stratified, you can do that. So just I add by sanitation facility. Then let us enter. Okay, I think some spelling error in the random. Okay, I make spelling error in the random. Random. Okay. So RAND random. Now let us run. So now you got this among total overall 0.69. There is no change. In previous also 0.69. But when you use fixed effect model, the value becomes 0.72 something. But in random effect model, either you do subgroup analysis or not, but the overall pooled prevalence will be not changed. That is 0.69. But if you see now here, what extra things you will be get, what is the prevalence between the improved sanitation facility group as well as that. So then you can say here 0.68 and another is 0.71. That means not much difference between these two groups. So this way you can do that. But most important point is here. No, here you need to organize your data, pool your data in that proper way. That proper way means definitely you will have a data matrix this way. You know that your study, you can study 1, 2, 3 can give also. If you have any subgroup analysis, you can have put. So you can have different subgroup analysis. But remind it, when you see any subgroup analysis, you found exactly in that group. Not take total. Suppose one study is provided, there is no improved and unimproved group, whole over they given. Then in that case, you exclude these studies. Otherwise, what happen? It will be affect the overall pooled effect size. So you can see total number of persons using total number of persons using improved sanitation facilities. Among them, how many have unsafe disposal practice? Just this number you have to extract from the data. But again and again, I'm saying that sometimes it is not given very directly way. Sometimes the given percentage you have to recalculate, and you have to do that also. So, but you need these things. But when you extract the data, many times you will see that some of the studies you feel it is eligible, but you may not get the data. But if you don't have the enough data, then you cannot do meta-analysis. At least 3 studies needed for the meta-analysis. At least 3 studies you need for the meta-analysis. If more the studies, then your result will be more correct. Then you can do, suppose I have very less studies, then how can I do sensitivity analysis? Some studies very less sample size. Now this study, see, unimproved sensors 31 and 31. If I want to do sensitivity analysis, I can remove these studies from my analysis also, because out of 31 something bias or some different type of study is there. Sometimes it's very high sample, like unimproved sanitation 26, that these studies have very high sample also. So you can use funnel plot, see the heterogeneity of the studies which are outlier study, then you can accordingly do. But for doing that sensitivity analysis, you must have enough number of studies, otherwise you cannot do that. Okay, so this is all about the prevalence, how to do prevalence, means meta-analysis for prevalence or proportions. So sir, is there any questions or anything else? We can take some questions, then we'll go for the diagnostic accuracy part.
Sir, I have a question.
Is it? Yes.
So
yes.
Where do we use Simonian and maximum likelihood method in this?
Where
do we use Simonian and maximum likelihood method in the meta-analysis?
Yeah, that is again when you are trying for RCT as that. But here that simply you are using the pooled prevalence. Here simple pooled prevalence you are using. But that is when you are doing advanced meta-analysis using RCT or network meta-analysis, then you need. But here simple prevalence you are using. In the proportion stage, in the prevalence and proportion stage, it's not needed.
Okay.
Okay, now let us focus on the another part regarding the diagnostic accuracy studies. Okay, so let us see. So how many are aware about this? What is diagnostic accuracy studies? That diagnostic accuracy studies are crucial because they assess how well a medical test can distinguish between patient with and without a specific disease. That means the diagnostic test accuracy provides evidence on how well a test correctly identifies and informs subsequent decision about the treatment. It's very important in both for the technology people or innovator. It is very important for the technology people. Why it is important? Because when they invent the new technology, new diagnosis device, the diagnostic accuracy is very important. But how accurately this instrument is detecting the disease, it is very useful for the healthcare provider also. Either they will be rely on that instrument or not. If the sensitivity and specificity is very low or high. So therefore, this diagnostic accuracy study is very important. And before the meta-analysis in diagnostic accuracy, let us understand what is actually diagnostic accuracy. Let us see that same example as a anemia. So when you are testing anemia, so you will be say that either anemic or non-anemic, then you will be take the blood samples, then you can use the different analytical approach, like then you can test. So you send the blood. So what is the gold standard for the anemia testing? You can say hemolytic analyzer is the gold standard or reference standard. So till now we can say that hemolytic analyzer. But that when you are using hemolytic analyzer test, it may not available in all setup in the rural and remote area. It's because there again you have to carry the blood from the field to this facility where this hemolytic analyzer is there. Then you need also venous blood. When you need venous blood, and to draw the blood also you need a trained healthcare provider or trained lab technician who can draw the venous blood also, because everyone cannot take the blood, venous blood. So these are the hindering. In that case, there are various other invasive technologies there which only take the fingerprint blood. Then they can say the test at the point, means you can go to the community with a portable machine. There you can take small amount of blood from fingerprint. There is no venous blood, and anyone can do that with the minimal training. Even if ASA can do that also with minimal training, community health worker to do, or anyone can do. So okay, another method with the advance of technology, there are now many AI based technologies that are non-invasive. So you don't need to fit the needle, or there is no medical waste, nothing is there. You just use the AI device in the finger tip, then they will be give the correct percent hemoglobin value. Okay, then you can calculate that. So if I want to do that, suppose there is a non-invasive method available. 3 instrument is device A, device B and device C. 3 device है, तो इसमें मेरे को एक device. So I have to choose one device for my implementations. As a clinician, you need, okay, which one is best device. As a policy maker, we can thought that, okay, state should procure the best one, and which is ultimately better for the patient and for screening purpose. This small machine you can carry to the field, you can do on the spot, then you can do that. There is no need of needle or any pain for that. But the point is that the question is that how accurate result these studies, this instrument are given. Without knowing the accuracy of this instrument, we cannot promote it. So therefore, once this technology developed, the company, the industry, they funded third-party validation. So in the validation, they generate the diagnostic accuracy data. So what they do, they took the test the hemoglobin in hemolytic analyzer, gold standard, and they will retest the test in the device A, for example. Then they will be match the result of device A with the gold standard. Then they say how many correct result will we get. Similarly, other device B also, they have same things. So that is called diagnostic accuracy data. So comparing each new technology, new innovations result with the existing gold standard, then we'll say that how accurately the result is giving. Then we can based on that. So once you do this test, so you can generate the data. Then you can also, there are some diagnostic measurement parameter or value. I'm not going detail. Sensitivity is there, specificity is there, projective predictive value is there. So these are not, I'm going to detail about that. But simple things, you need this type of table. So what we need in you are comparing. When anyone is doing the diagnostic accuracy studies, they're comparing. Gold standard here, 416% tested, that is the reference standard. Second, the new device index, let it be device A here, index test. So index test giving positive, your gold standard is also giving positive. That is called true positive. 184 samples given both the device in the positive. That is true positive. That is correct also, because my new device, my technology result is matching with the gold standard. That is true. Similarly, if the gold standard is giving negative, my device is giving negative, that is true. Okay, that is true negative, because my result is matching. But sometimes, sometimes what happens, your device is saying positive, but the gold standard is saying negative result. That means your device is saying disease, hemoglobin, anemia, hey, but then the gold standard is saying there is no anemia. Or you can say other way, your device is saying, hey, disease, hey, but gold standard is saying disease nahi hai. There is no disease. In that case, it is a danger. That is called false positive. So similarly, sometimes your device is saying there is no disease, but gold standard, as per the gold standard, there is really disease is there. Then that is called false negative. You know that both the cases are very important. Both the cases will be say that if false negative is 0, false positive is 0, definitely the sensitivity specificity will be 100%. Based on that, we can say that how accurate is the device. And for the clinical and public health importance, why false negative and false positive is important? You know that false negative test does not detect a condition when it is actually present. When test does not detect conditions when it is actually present, then what will be happen? There is definitely consequence for the patient. There is definitely the latter stage when the disease will be detected. If cancer, you know that the correctly will not identify screening stage, then it will be become the third stage. Again, the treatment will be very difficult. There are a lot of consequence. Sometimes if it is a infectious disease like tuberculosis, if you will not detect, then it will be spread in the society also. If other way, if the other way the test is saying false positive, that means what will be happen? The consequence here test detect a condition when it is actually absent. Then what will be happen? Here also consequence. What happen? Then you will be send the patient for the referral also. Okay. When the referral, there is out-of-pocket expenditure, there is unnecessary overload at the facilities. Then sometimes also you have also unnecessary treatment also. You know that is also consequence. So these true false negative, false positive, true negative is very, very important. So when you do a diagnostic accuracy study, then you need this value: true, how many true negative, how many true positive, how many false negative, how many false positive. In each study, these values are necessary. Sometimes they are given sensitivity, specificity, but ultimately when you do meta-analysis, these 4 values are the important. You know why meta-analysis of diagnostic accuracy study is there? You know, a same instrument, there are 4 or 5 studies or 2 studies sometimes. So they have different results. So how you pulled the value, and once you pull the value, then you can say that okay, this instrument is good, this instrument is useful based on that sensitivity, specificity, because you are summarizing the evidence. So it's combined the result from multiple studies and produce a more precise estimate of a test. Okay, then it sometimes also identify bias and study quality. So when you are using any systematic review, there is a standard quality assessment, or we called risks of bias assessment checklist also. For different type of study design, there are different type of quality assessment checklist. I think yesterday Dr. Geeta Menon ma'am explained you detail. So then you can also identify the quality of the studies. Then you can remove from your analysis also. Okay, although their study is very low quality, very, very low quality studies, then you can remove from your meta-analysis also. Because it is very important for the cost effectiveness and resource allocations, you know, that help policy maker which tests are worth in implementing based on the accuracy. But sometimes some states want, okay, we want to, there are a lot of non-invasive hemoglobinometer, we want to, which one we should procure, which one we should use for the patient preparation test. Then you have to see this you have to find out how many diagnostic accuracy study are conducted in that particular instrument. Then you find the overall sensitivity, pool sensitivity and specificity, then you will see which one is more useful for the screening. So ultimately, this systematic meta-analysis of diagnostic accuracy study useful for the clinician, useful for the policymaker, and research determine if the diagnostic test is reliable and applicable in a clinical practice or not. That's why it is very equally, this type of study is very important for the clinician as well as the persons, even if industry or technology people also, the skill is required, because sometimes what happen, no, they are not able to generate good quality diagnostic accuracy data, then it is very difficult to say that either the study is reliable, this instrument or technology is reliable or not. Okay, so now sometimes I told that, okay, the value, like the prevalence studies, you have to extrapolate the data, you have to correctly extract the data. If the study have not data, desired data, you can exclude from the meta-analysis. Similarly, this way you have to sometimes they present sensitivity, specificity, this value. Now you can calculate the true negative, but you know that what we need true negative, true positive, number of true negative, number of true positive, number of false negative, number of false positive for our meta-analysis. Even the given sensitivity specific, some study they guide directly when this value, you take it, some study they have not given. So then you can calculate. Let us example. So that is a formula is there. You know that, before meta-analysis, you have to do a lot of exercise for the systematic review and proper data extraction. Once you have a, yesterday I have a talk with Vivek sir that if once you have a Excel sheet, adequate data sheet, which may need 6 months, 7 months to extract, screen, extract everything, then the meta-analysis could be done within the 5 minutes or 10 minutes also. But to reach that position, to reach that data sheet, you need many months to reach the data. So suppose if the formula for sensitivity is that, okay, true positive by true positive plus false negative and probability of correctly detect the disease here. Specificity similarly, probability of correctly detecting the absence of disease. Okay, suppose you have, what are the steps for calculating this TFE, NFE, FE exactly? So you need total populations. In that study, how many number of population they studies, and what is the prevalence of disease, proportion of actually disease cases in the population, you need this value. Then you need sensitivity and specificity value. So if these things are given, then you can calculate the TFE, NFE, FE, FN, which is more essential for the meta-analysis. Okay. So here the formula is that actual positive cases is equal to total population into prevalence. Actual negative cases is equal to, then you can minus the actual positive cases from the total population. This is the formula. Okay. Now you can calculate the value in step 2. TFE is equal to P into sensitivity. Okay. So Fn is equal to P minus Tp. Tn is equal to N minus Sp. Nowadays, no need to remember the formula. You can keep the formula in front of you and you can calculate. Even you can easily calculate using Excel sheet or any software also. So this is the latest formula. So now, based on that, just this population is there, total population is there, 1000 population is there, prevalence is equal to 10%, that is 0.1, sensitivity given 90% and specificity given 95%. However, in that study, there is nothing given regarding the value of how many true negative, true positive, all the value is not given, but this much of value is there. So my question is, can you include that study for our meta-analysis or not? Because we need true positive, true negative, false positive, false negative value. However, this much of information is there. They are not given any value related to that. My first question is, can you include these studies in our meta-analysis or not? Anyone can answer. Yes or no? जितेंद्र सर,
यस सर, यस सर।
यस, क्या सोच रहे हैं आप? यूज कर वो स्टडी को हम यूज करना ना नहीं करना, निकाल देना फिर?
नहीं करना है सर। वी कैन कैलकुलेट द
Okay, करना तो then you can calculate. Now I have given the formula. Now based on that, please calculate what is TP, FN, TN, FP. Using this, just simple exercise. What could be the possible? Because if this value is there, you have to remember this formula. Then you can use this and calculate what is the value. If you remove all the studies, you know that then nothing will be for the meta-analysis, because the persons, the innovators who presented the data, they presented not for you. You will use their value for the meta-analysis, but I will be rather suggest nowadays, if they present along with this value, it will be very easy for the person, those who are taking for systematic review. If not there, at least you can calculate. Now, if you use this, I'm not testing, then you will be get this value. You know that the actual disease cases is equal to 100. That is total population into the prevalence, 0.100. Then n is equal to 100 minus 100, 900 healthy cases is there. So total 100 cases and 900 healthy cases are there. Then you compute TP is equal to 100. That means actual cases into sensitivity. Sensitivity is equal to 0.9. 9 is the 90 is the here TP. Then FN is equal to 100 minus 90. No, true, false, negative. Total positive cases, but how many are really positive? Then you can TP. Then you can get 10. Similarly, TN is equal to 900. And what is 900 here? Total healthy cases and the specificity 0.95855. Then similarly, F is equal to, then you can minus 900 minus 855 is equal to 45. So you need this 90, 100, 90, 10, 855, 45 value for doing meta-analysis. If that study is not clear, not correctly given, you try using the formula, then what will do, you can exclude the study, but this value is needed for the meta-analysis. Okay, similarly other formula is there. I'm not going to detail explain this formula. PPV, if NPV PPV is given, then sensitivity specificity is not there, then first you have to calculate sensitivity specificity, then you go for the other true negative, true positive, this value. You have to do certain exercise for that. Okay, once you got this, now you got a beautiful table like this. So here reference standard is all is that, you know, that gold standard, then एक teacher का खाता दूसरा कोई देखा, दूसरा को कोई देखा, we cannot compare. So here all the cases, device A, B, C, they prepare with compare with hemolytic analyzer. Sometimes, you know, the gold standard comparison group is different. We should not include that studies. The gold standard always be, you know, the मेरे पेपर दूसरा कोई देखा, दूसरा का पेपर कोई से देखा, ऐसे मार्क नहीं होगा. If your gold standard is hemolytic analyzer, all the cases, that is good, you include that study. Then your technology B, C, D, suppose A, B, C, 3 type of technology is there. So here this sensitivity, specificity, this value is given. Then based on that total sample, then how many TN, FV, FN we get. This is needed. This is a simple table, you know, when I do any systematic of diagnostic accuracy studies, this simple thing is needed. Once you got this value, now based on that, you know, by looking this table, can you say that which instrument is good? A, B, C. Which device is good? Anyone can answer which device is good? A, B, C. Without any meta-analysis, by this is the table, summary table, sensitivity, specificity is there. Then which one you think that it is good? Anyone can answer?
Device B is good.
Device B is good. Okay. So any other answer? No, device B has 90%, 95%, and one study is saying 73, 51 also. Device B 22 also, 94 also. So I think it is very difficult to judge if this value is given. No, actually device B. So you, as a clinician, if you seeing without meta-analysis this data, device B, it may get trouble, because device B, some cases sensitivity is 22% only, some cases it is 90%. But how will I will be combine these three studies result? If I want to compare the what is the overall sensitivity and specificity of the non-invasive approach. This all three are non-invasive because they design based on the AI tool, non-invasive approach. You don't need pick just a laser based or AI based technology they use using this three type of non-invasive approach. Even more, sometimes you will get more 5, 6, 7 types of also. I have just given small example, simple example to understand it. Now let us see, interpret it, this result using a form of meta-analysis. This is the command for STATA command for meta-analysis. You have to install meta DTA. If in your STATA beginning, once you SC install meta DTA, once you install meta DTA, simple write this command metadata, then write TF, FN, TF, then study ID. Like there we say level, here you gave study ID, study, then model, random model, stratified by technology. If you will not get give stratified by technology, it will be give overall. Suppose if I want what is the overall diagnostic accuracy, sensitivity, specificity of non-invasive one, then I no need to stratified technology. But if I am interested to that which technology is good to use for the clinical practice or the public procurement, then I have to do a stratified meta-analysis. I have to stratify by technology. Here technology is A, B, C, 3 technology. Let us see how it looks. So this is result meta-analysis without subgroup analysis. Here it's a what is the this figure says what is the overall sensitivity and specificity of non-invasive hemoglobin test. So here the sensitivity, overall sensitivity is 0.77, overall specificity is 0.83. That means still we have some false negative and false false negative cases and positive cases also. So this is the overall sensitivity. The command is simple: metadata, TF, FE, FN, TN, that value you can write, then study ID, then model random. This is the simple command I run. But you know that anybody have STATA, they can run the command, they will be get this picture. But most important exercise that how competent you have to extract the data, correct data for the meta-analysis. No, correct data extraction is very important. If I do a subgroup analysis for this, then by interpreting this, what clinician answer? Can be clinician able to say that which device A, B, C among this, which device is good, which device I will be used for my clinical practice, which device I will use for a policymaker, which device I will use for the public procurement? No. This answer not say, but this will be say that okay, what is the diagnostic accuracy of non-invasive one in comparison to invasive technology. But here again you have to compare invasive versus non-invasive, which the data we don't have in these studies. Okay, now exactly answer to clinician which device they will take, or policymaker which device they will be used for public procurement. This meta-analysis will be answer. Okay, before that also you can do some SORC, then that will be come to later. Let us see the comparison also. You know, here what I do, same command, only I stratified by technology. That means a variable is the technology. Then it's a device B, device C, device A. Now this figure, you can say which device is good, B, C, A. Anyone can answer. What you see? As a clinician, which device you will choose? Already you understand what is sensitivity, what is specificity. Now this meta-analysis help you to do that. Meta-analysis say what are the existing study in the device B. We systematically review, find out their value, extract the data. Then similarly for C, A, what are the all the studies we pulled, and they have the this much of data, sensitivity, specificity data. Now based on the things, which one you will be purchased? जितेंद्र सर, आपको क्या परचेस करना है उसमें, डिवाइस बी, सी, ए में?
I think device C.
डिवाइस सी सर, क्यों? 8165, ओके. डिवाइस, अच्छा, ओवरऑल वो दोनों का 7 ओवरऑल गिवन, बट ओवरऑल इज नॉट नेसेसरी हियर, बट बिकॉज हियर से दैट, ओके. सर सेड प्रीवियसली डिवाइस सी, बी 78 and a 96 and that. So sometimes although it gives value, you know that you did other exercise, this is not part of that. You can see also feasibility, you can see also the scalability of that company, all things you can do. Then if you do STA, then you can say also cost effectiveness, what is the cost, but before that cost, the effectiveness is very important here. Effectiveness is that sensitivity, specificity. So sometimes you cannot judge this, but you have another graph will today generate, is this SORC curve. No, why use the SORC in meta-analysis? It adjusts for variability in threshold across studies, provide a single measure of overall test performance, and helps compare the different diagnostic tests. It's compare, it's overall. We do not have any device. It's compare. Okay. It's compare AUS close to 1 indicate excellent diagnostic accuracy. If you AUS your that area under curve is near to 0.5 suggests poor discrimination ability. That means how close to 1.0 AUS is excellent diagnostic. So now let us that 3, because here it's just for the all pooled things. Now in this graph we can say what this graph is suggesting: device A, device B, device C. So this is the summary of ROC, that is called SROC plot used in diagnostic test accuracy meta-analysis comparing 3 diagnostic device, that is A, B, C. These 3 meta-analysis we did, A, B, C, 3 SORC is giving. So we can use both meta-analysis as well as SORC plot. So if you see overall diagnostic accuracy, the closer a curve is to the upper left corner, up to it's close to 1, no point, then upper left corner, close to upper left corner, the better test perform, high sensitivity and specificity. So if you see device B, the black color one, is closest to the top left corner, indicating the superior diagnostic performance. You know, here if you have to judge from the graph only, it's the black one is the B, which is device B is very closer to the upper left corner. Device B, okay, if device C, that is the red one, which are shows intermediate performance, and device C, green, it's relatively less accuracy based on its positions. If we say curve safe and confidence regions, each device dash curve represents its summary ROC curve with confidence bounds. Wider the curve or more spread out the curve reflect more variability. That is more heterogeneity. If there is more heterogeneity, then the result is not reliable. So device C shows a broader curve. If you say device C, which is green color, which has a broader curve, that means there is more heterogeneity, suggesting more variation in test performance across the studies. Again, sensitivity versus 1 minus specificity is given. points nearer to the left upper corner, low, that means 1 minus sensitivity, and high sensitivities are preferred. If you see device B achieve this balance best, that means device B is black color, which is close to the upper left corner, and if you see similarly device B also, it's a close to the left upper corner also. So upper left, so that therefore your decision is true. You can choose the device B. So you know that this is very important for the clinical decision. This is very important for the policy decision, meta-analysis. Okay. Now if you see the overall implication for policy and practice, device B demonstrate the best balance of sensitivity, that is 0.78, and specificity 0.96. Device A perform reasonably well, but with slightly lower accuracy. Okay, if you see 89, 72, but how you got this? No, it got from the both the forest plot as well as from the SORC. If device C has least reliable, because among the three, because the sensitivity is 81 and specificity is 0.65. So this type of meta-analysis will be very useful for your clinical decision as well as for the policy maker for the policy decision also. So this is all about the study. Let us see in practical with a data set. Let us open my STATA. Okay, let me. I think my screen is visible. Jitendra sir, my screen is visible.
Yes, sir. Yes, sir.
Yes. So now I am browsing another data set, diagnostic accuracy data. Open. I just click on the import. Okay. Now, okay, same sheet I can use. Now my data sheet is ready. So if I can, what are the variable here? Describe. I can check. Here I just check. Okay, these are my variable studies there. Reference is not needed, but technology is very important. Sensitivity, specificity, PPV, NPV is not there. But what I said, this TP, FP, FN, TN, these are the most important point here. So what is the command here? What command I wrote previously? This is metadata. This is, you have to SSC install metadata first. Already I have installed it. I'm taking this directly. Okay, I'm taking this command directly. I'm just copying. Okay, so what I wrote, meta DTA, true positive, FP, FN, TN, and you must say that your data set must be organized in this way. Study ID, then model random. If I just run it, it run. Now it give a forest plot. Okay, it give a what I show you in this is a forest plot with this sensitivity and specificity. But you know that this is STATA, but if you can do this other also, sometimes see even if Python or other also, the sensitivity specificity you have to get. Meta DTA is there also. You cannot get a same figure, but STATA is have certain recently developed how to do diagnostic accuracy study in STATA. They have recently developed some command, and this is very that we know every software they're working and advancing that things. Some sort of things are very good and advanced in R also. For example, if you want to the pooled value for the mean cost or median cost, I don't think that STATA have that capability. Maybe STATA 19 we have to check. Otherwise, for that you need R. Okay, I don't think that you could learn all R, STATA, everything, but once you extract the data in a correct way with the help of a statistician, you can give that value to the statistician. He could run the model in a different way. So you know that for me to organize this data take a lot of time, but for running it is within 1 second or 2 minutes I am running these things also. And then interpretation definitely need a more time. So this is that. If I same curve now I remove stratified part just from the model. Okay, same. Let us see that some model. I am just removing the model random meta DTA. Then I am just removing this part. See, this is SWRC given, very nicely given, because here there is no only combine one technology is there, that therefore there is no difference is there in which technology is best, because I am combining all studies together without any subgroup analysis or by technology. That's why you are getting here observed data, predicted region, that is given. But if you see forest plot also, there is no classification, there is no group. It's given overall sensitivity and overall specificity for the non-invasive one. Again, you know, that same things, but for our region, for policy decision, this is very important to have with the stratified by technology. So you can stratified by technology, you can suppose there are many, when you are doing diagnostic accuracy for AI based technology, oral screening or any other things also, there are different AI model is there. So you want to see that which AI model is good, high sensitivity and specificity. In that case, you can classify them as a model. Then you can say AI tool also using different data set for Asian region data, for American region data, for European data. Then you can stratify it as per the region wise, which data set have or which of the study, which is set up the study conducted the high accuracy results. You can do also, you can stratify it in many ways. So here given sensitivity, specificity, overall, so detail is given here. Just I can run, it run, automatically come. SRC a plot here. See, simple command. The main chunk of work is that after data extractions, systematically review. If you suppose if you do not systematic review and you are not identify the article in systematic way, suppose 2-3 study you remove or exclude, then the pooled effect will be definitely affect, because there are studies is there. Suppose this technology B, you forget the study that BASA ETL, which sensitivity is 0.22. If I remove the studies and the specificity is 0.95, then if I remove the studies from my analysis, then the result overall pooled as well as the device B value will be changed. So that's why systematic review is more important to include as much as possible related studies. Second is that if you are not able to extract the data properly, then you cannot make. This system is giving, if I just I remove one column from the data, let us see that I assume I just remove TN, my data TN is not there. If I remove TN, let us run this model, it will give no too few variables specified. If your value, the one data value is missing also, then, but definitely you have to calculate. If that study you are not able to extract the data, then you can exclude from your meta-analysis. That's all. So this is the thing. Similar way, this SWRC also is given very nice way. You can interpret also. If you don't know how to interpret also, you can take the help of some statistician also can help you. Okay. Okay, let us do this very quickly, this final part of this part. Suppose randomize, now there are two drugs, there are two surgical procedure is there. Let us be IFOM or open hernioplasty for the ventral hernial surgery. These are two technology. There are many studies are there. So which one you can say is that based on the available study. For example, I took two outcomes. One is wound infection, another is duration of surgery in minutes. So this is gone from, that whatever the studies present this outcome, you first identify the total. These all are the randomized controlled trial studies. You can identify all randomized controlled trial studies. Then you search how many studies present these two outcome. Then you can prepare a Excel sheet like that for the suppose this is data sheet for the duration of surgery in minutes. So here the data extraction sheet is that little bit different. If you want to do the continuous data, the mean, duration, then you need mean as well as standard deviations. If you want the value in odds ratio or relative risks, for example, the wound infections, there either you can use relative risks or odds ratio. Whatever the studies provided that value, you can take that. So in this case, for the duration of hospital stay, duration of surgery, time, that in this case you need to have this type of data set. First study, this is 1, 2, 3, 4, 5 studies. Then you say here, since they are the RCT intervention study, you have one group on the intervention group, other is the control group. You can say what is the total intervention group in each study, what is the total in the control group. Then mean in intervention group and SD in intervention group, then mean in control group, SD in control group. So these data you have to extract in the Excel sheet, or you can use formula, or if direct is given, you can directly take from the paper, whatever this data. For example, if you want to analyze the mean durations, however, some studies not provided SD data, either you can calculate using formula. If not, it's provided, then you cannot do meta-analysis that. So you can exclude that studies if you are not able to provide this value. But these value are very important. Once you use this value, then you can use the graph. Mean difference is that. So that means here say study 1, study 2, study 3, study 5, N total number, mean SD for the intervention as well as control group, N mean SD. Then it given the mean difference, then overall mean difference is minus 18.24. That means it says, and again you are using also a random effect model, high heterogeneity is there. The overall mean difference observed was minus 18.24. And with the 95% CI is equal to minus 54.6072 plus 18.12, which indicate that there is no significant difference in duration, because I'm saying that when you are doing meta-analysis, you also need some basic interpretation skills. Like if you don't know what is confidence interval, at least I'm not saying that you remember detailed formula for the confidence interval, but at least you know how to interpret the confidence interval value. Here p value is not there, so how to interpret this confidence interval value. So if then you can say, okay, since include the 0 here, then this is there is duration between both these intervention and control is not significant. Okay, further you can say that there is I square value is 99.68%, means high heterogeneity, indicate that substantial variability in the study also. So this is can judge that either intervention and usually if anyone surgeon, they know that which technology or which device or which procedure we can do surgery in the during less duration, because less duration means the production will be more, because then you can overall infrastructure, that overall gain will be more. If you can produce surgery, have 50% per day, if you have 5% per day, so if this take more duration, then you cannot do more patient per day. So it is very important. So then in order to decide that, you can say, is there any difference between the duration of surgery in both intervention and control group? But this study is saying, previous RCT saying, meta-analysis of RCT saying there is no significant difference between that. It may be significant difference, but in this case we are saying that. Similarly, another outcome is that what we took other outcome, that is the wound infections. If you take wound infection also, here the data extraction is little bit different, because that is the mean and ST, you can say, durations. Here outcome is binary. Event yes occur, yes or no. So in this case, you can say what is the total population in intervention group, what is the population. Okay, these are 1, 2, 3, 4, 5 studies again. What is the population patient in intervention group, what is the patient in control group. Okay, usually when the RCT, usually same number of patient in the intervention control, but sometimes it vary also. They may exclude. Here you can say 126, 127. The number of patient in the intervention group, number of patient in the control group. So once you get this value, but the software need two things, success and failure. So intervention, how many failure, how many success. 6 plus 120, intervention group, that is 126. Out of 126, there are 6 failure cases, 1 to 120 is the success cases. Similarly, each study in the control group also, you can find how many success, how many failure cases, because this success and failure is more essential for your meta-analysis. Once you do that, this is just you can use odds ratio, or you can use relative risk. This is the how you interpret it. So one is to the favor to the control group, or its favor to the intervention group. Based on that, you can decide. Okay, either you can take whatever the value they present, odds ratio or relative risk, what the study presented. But sometimes what happens though, you may not get the required amount data of some studies. So it is the challenges. That's why many times, although you get initially you thought to include 30 or 10, 12 study, you get maybe meta-analysis huge, very few studies. Okay, so but you have a multiple outcome. You can think that which study have similar outcome, you can present it. So if you say, then you can have calculate the risk ratio, and like this you can check the heterogeneity. If you see that, okay, what is the interpretation this graph? It says risk ratio, compare the risk ratio in the treatment group versus control group. If risk ratio is, because some epidemiological skill also you need. So what skill you need? You need definitely some basic biostatistics skills, how to interpret this value, and epidemiological skill also. So epidemiological study design along with the measuring value, like how to interpret the risk ratio. If the risk ratio is less than means is 1, then you can say treatment is beneficial. Then again you have to also see correctly put the intervention group and control group. If you don't know exactly which one is control group, which one is intervention group, then it will be mislead your result. So when you are doing the meta-analysis, you can see that all studies have same intervention group as well as same control group. Some studies, if they use intervention group as a control group, then other some intervention, then you cannot do that. But you take similar type of study who have same intervention and control group, then you can pull the result of that study. Okay. If there is no difference, relative risk is equal to 1, no effect. If it is greater than 1, then treatment is increases risk. That means it favor towards the control group. Similarly, using the confidence interval, you can say that if the CI doesn't include 1, the effect is statistically significant. For example, if you see that Mishra et al. Study, RR is equal to 0.81. If you see the Mishra et al. Study, RR is equal to 0.81. 0.81 relative risk ratio is equal to 0.11, then you can say that here what happened, which suggests statistically significantly risk reductions. But it's the analysis based on the single study wise. But if you took the pooled risk ratio, that is 0.98 pooled risk ratio, it says that small but statistical significant reduction in risks in the treatment group. What outcome we will taken here in this case? You take the this one is that wound infections in both the surgery. What is the wound infections rate? Means healing wound infection, recurrence of wound infections, healing of wound infections, whatever the intervention control group provided. So similarly, that means since the CI doesn't include one, so this form a random effect model accounting for variability between the studies. But before doing that, heterogeneity is very important. If you say I square value here 72.04, which substantial heterogeneity means over 50% is considered moderate to high. If I square is less than 50%, it is good, but here still there is a lot of heterogeneity study, but you don't have much studies, so how could you do that? So the overall conclusion is the treatment reduced the risks slightly 0.98, and this effect is statistically significant. However, the heterogeneity is high, meaning the result vary considerable across the studies. So the effect should be interpreted consciously. You know that although there is a positive side, positive towards or the intervention is favor towards the intervention group, but still there is a high heterogeneity study. If you have more study in this area, then it could have a best clinical judgment. Then based on this result, you cannot say that okay, your intervention is better than control group. So similarly, you can compare all the outcome, desired outcome or effectiveness outcome, then you can compare, then you can do meta-analysis of the study, then you can do that. Okay, for this quickly I'll show you one. Let us open the STATA file, import, just you can say successful outcome, duration of surgery. Let us do open. Yes, here I think here you have to go window base statistics, here meta-analysis, there you can click on the meta-analysis. Here in the, you can say compute and declare effect size two group comparison continuous outcome, because duration stay is the continuous outcome. You can choose if you want odds and other, you can choose second one, compute declare effect size two group comparison binary outcome. It is not yes or no, it is continuous outcome because duration of surgery, you can say. Then once you do that, you can say it's a main sum. You can pull the sample size total. You can just specify group 1, specify group 2. So suppose I took group 1 as a intervention IPOM, then I can say total sample in IPOM, then I can say mean IPOM, then standard deviation of the SD IPOM. Similarly, specify group 2, that means control group. Control group means total open, total. This value is needed. You have to extract during data collections and prepare your Excel sheet accordingly. Then mean open, then standard deviation in open, SD open. Okay. Here someone asks the questions, either need the head regression or not. That you can hear you decided that. But you know that when you do prevalence studies, it's not necessary. Then once you set up this value, you can submit, but then you can go to the forest plot. Here you can choose random effect model. Okay, then submit. given, but I have not chosen any value. Then he can also plot options in the forest plot. You can choose forest plot, then option forest plot. Okay, plot options. You can choose draw effect size line, or draw no effect size line. You can draw. Okay. So you can do this. So here it's given 90% CI weight. So you can see that what is the differential, but I square is still 99.87. You can choose using random effect model. But most important thing is that you need all these parameters. Means you have to extract all these parameters correctly. Then only you can run this. Yes, same model also you can run in the start R also. But principle is same. But you know that sometimes what happen, there is little variation in the result, but it is not much, 0.1, 0.2% vary if you use different software also. But but you can get not much variation in result if you use different. But point is that whatever software you use, or even if same thing also you can do using Excel also. Excel have also many powerful powerful packages you can include, and you can do also prevalence study meta-analysis using Excel also. There are other advanced, if anyone you want to use the randomized controlled trial study or intervention study, so they can visit Cochrane and they can use their site instead of STATA or R. But sometimes all the software some limitation also. I found, R has some strength like a mean cost data that which STATA cannot do. But as Dr. Jitendra also rightly told that now every so when you get advanced version of the software, they're adding this feature gradually. But I found for the diagnostic accuracy, if you go to more detail for AI modeling, then STATA has limitation for diagnostic accuracy studies, which Python and other software can do that. But if you want to do systematic review, you first thorough your objective and extract the all the correct study you find out. Then once you find out the correct study, extract the data properly. In the sense, if you want to do meta-analysis of relative risks, if you meta-analysis of mean difference, if you want to meta-analysis of prevalence, if your study is diagnostic accuracy related meta-analysis, each study, you know that there are different form of data analysis that you should be carefully do that. That means in your protocol, it should be clearly mentions all these studies are diagnostic accuracy, then my data analysis plan will be this way. So that is important. I think I realize that in the online it is difficult to make a hands-on practice, but this is one orientations. If Vivek sir create an opportunity in future, the DHR team will be moved to the Northeast and they're ready to teach more. But I think before coming, you should come with your systematic review, your data, then take the help of statistician, then they can help you. Thank you, sir. Yeah, I think same R also they will be learn same technique, but yeah. Yeah. That's why Stata is a paid version, no? Are you no money? Stata is taking money for that.
For for STATA, I
Chitendra
will
sir.
take care. Don't worry. I will take care. I have STATA. If anyone interested, I will give.
So these all participants are from medical background or heterogeneous background. I didn't have time to interact, but they are heterogeneous background. No, good. Yeah, maybe we can take feedback from one and two participant within maybe in half second or something. Then which could be useful for advanced designing. Yeah, you can. Anyone want to? No, sir. Sometimes what happen, the faculty have limitation. That the software has limitation, the technology have limitation. So everything is limitation. But within this scenario, also we try to best, because I give my lecture not as a biostatistician perspective, as since I am in HTA and real policy decision. So I gave how we could effectively use the meta-analysis for the policy decisions. So that perspective, but if you hardcore statistician perspective, then it is different. So that's why things become complex and simpler as per your professional background also. Yes, exactly. Tomorrow morning you say, "Nah, that I keep in mind." But many of them are also, I know that you may not perform analysis
Good
because
evening,
those
sir.
who don't
Good
know
evening,
the
sir.
strong statistics. Yeah, good evening, please.
Uh, Sir, I am from statistical background, but I have no knowledge about the meta-analysis. That is my second workshop I have attended, and know about that meta-analysis can do solve uh, very much orderly all the problems that we have. Sorry, sir, my sentence are
Yeah,
not.
yeah, yeah. I got. So you say that meta-analysis is very useful tool to for the policy decision and support the problem. But till I don't know meta-analysis how helpful for the statistician. But I can say that statistician are helping policymaker and clinician to take correct decisions. So without the statistician, I may fail to explain the SRC curve and how that. So they can easily useful, but all the statisticians must have the some medical or technological skills, then they can understand. And the some other medical faculty, I'm not saying that they can become the expert like statistician, otherwise the statistician lose the job, but they have also enough skill to explain what they need exactly to the statistician, that they can write the commands
Sir,
in such a way they can
I have
explain
a
the
question.
data. If Yeah.
Can we perform meta-analysis in distribution theory analysis for that's meta-analysis is generally
Yeah,
used for medical clinical purpose? No, if we can purpose it for theoretical purposes, theoretical analysis.
you can do, sir. There are certain, advanced meta-analysis, network meta-analysis there. You can do that because we think in the clinical and propose. But definitely, if you are justify your problem statement justify your objective and a rational why you need meta-analysis, you can do that also. And you can review some of the study or advanced literature in that area. If not there, if you justify it, why should you need meta-analysis that area, that can become a methodological paper for you, that you could do. But I don't have idea regarding that, but definitely you could do.
Okay, sir. Thanks.
Yes. I have to
So
learn more also, sir, because my STATA meta-analysis limited to policy and clinical decisions. But that for that maybe Dr. Jitendra or some both integrated approach is necessary for the advanced statistical skill with the meta-analysis skill also. It's very essential. But now everything we see, that what is the clinical importance, what is the policy importance, everything we our mind setup is changed accordingly. We have to find out these things. Yeah. Yes. Yes, sir. Yes, sir. Yes, sir. Yes.
Dr. Vivek. So Dr. Sahu sir is very busy person. Now he is in Odisha. Tomorrow evening he will be in Delhi. तो पूरा DHR सर संभाल रहे हैं। आपको और अच्छा पढ़ाना है
अरे
तो
नहीं।
2 दिन सिलचर में बुला लीजिए। सिलचर में वहीं रह के फिर पढ़ाएंगे अच्छे से। हाँ, या
Okay, I think sir, Dr. Gita Mom is also good, and we have many times doubt in the statistics, sir, that she could solve the issue. Interpretation part is very challenging in some for me also. But although I am from public health, I study biostatistics. Not I am hardcore statistician, but know that sometimes I see integrated working with like Dr. Jitendra, Dr. Gita Menon, and it's very good because. But we have a strong public health skills, what to do, what not to do. So now it's world is very integrated, and many time we are working with the IIT also. These people, they also know that. So it is part of whatever background. If you have these skills, it is very useful. And don't think that we can learn everything. You can collaborate and you can support each other. That is very important nowadays. Yes, sir. Exactly. Yes, sir. Thank you, sir.
you can touch with the Sahu sir for funding also.
Thank you, sir, for giving opportunity. Thank you all all the participants and colleagues for patience listening. So that's yeah. Thank you all. Thank you, sir. Good night. Good night. Thank you all. Jitendra sir, bye.
बाय बाय सर, बाय। अभी थोड़ी देर बाद विवेक सर हम लोग बात करेंगे। अभी ओके।